Hi folks. For those of you that don't know me, I'm Nicole Ammon. I'm a licensed professional clinical counselor supervisor, and I work in the Department of Psychiatry's Best Center with a focus on integrated primary care and mental health care. So today we're going to talk about sexual health and how it is an integral aspect of general health and integrated care. We don't really talk about sexual health in polite company, but sex and sexual health is a major part of nearly every human life at some point, and good sexual health is a basic human right. The World Health Organization defines sexual health as a state of physical, emotional, mental, and social well-being in relation to sexuality, and not merely just the absence of disease, dysfunction, or infirmary. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, or violence. Research indicates that individuals with serious mental illness, such as psychosis, have lower rates of being in long-term romantic relationships, including but not limited to marriage, and lower rates of sexual activity in the last 3 months. But that said, like all human beings, normal sexual development for the people we work with includes ambiguity, exploration, and changing needs over time. Assessing sexual health can give a healthcare team important information about the patient's health, well-being, and health goals. Sexual concerns or dysfunction may be cues to undiagnosed health conditions. A large meta-analysis demonstrated correlations between erectile dysfunction in men and increased risk of negative cardiovascular outcomes and all-cause mortality, as well as finding that sexual health concerns are associated with things like obesity, diabetes, obstructive sleep apnea in men, and metabolic syndrome in women. Additionally, collecting sexual orientation and gender identity information as part of a sexual health assessment would allow providers to address problems that drive disparities for LGBTQ and similar minority populations. Across sexual orientation groups, 22 to 42% of respondents who report experiencing a persistent sexual health concern over the last year. However, the percentage of respondents who reported talking to their provider about their sexual health over the last year was only 8 to 15%. There was no significant in-between group differences there. And this gap demonstrates the prevalence of sexual health concerns versus the extent to which they actually get addressed. The participants you work with potentially face a higher number of sexual health disparities. People with serious mental illness diagnoses have been found to be an increased risk for engaging in higher risk sexual behaviors, putting them at a higher risk for STIs. Women with mental illness have similar pregnancy and parenthood rates to the general population, but they are at an increased risk of unplanned pregnancy, having pregnancy complications, including miscarriages, worsening mental health symptoms during and after pregnancy, and potential for custody loss. They, in addition, have higher rates of abortion. People with serious mental illness experience elevated rates of sexual assault and intimate partner violence and abuse. A 2019 article noted that in a survey that was done in the UK in 2015 had found that 40% of female patients who had had contact with secondary mental health services of some type had experienced rape or attempted rape as adults, and that 10% of them had experienced sexual violence in the last 12 months alone. They also note that more than half of those who had experienced rape or attempted rape reported having attempted suicide as a result of their experiences. In a 2024 systematic review of 26 studies that occurred between 1989 and 2020 from a range of countries across the globe, the studies consistently showed a high prevalence in the past year in adult lifetime sexual violence victimization amongst psychiatric service users, with higher rates found among women, more among women than men, but both male and female psychiatric service users across that wide range of time were found to have an increased risk of experiencing sexual violence compared to controls. People with serious mental illness are also less likely to access routine reproductive and sexual health care services, including protective contraception, preventive care, and screening. For example, numerous studies have shown that women with schizophrenia have lower rates of screening for cervical cancer, although there is some evidence that screening rates improve if a woman is more generally engaged in healthcare overall. No, although causality remains uncertain, exposure to prolactin elevating antipsychotics for a year or more was associated with increased odds of breast cancer in women that had severe mental illness. So when prescribing antipsychotics, the shared decision-making process should really include consideration of individual risk factors for breast cancer. When looking specifically at sexual and reproductive health for young participants, literature notes that adolescents and young adults with general experience have a disproportionate burden of sexual and reproductive health outcomes. Sexual vulnerability at this life stage is associated with initiation of sexual activity, relatively poor health literacy, and a higher risk of sexual exploitation. A systematic scoping review pointed to empirical studies and case reports focused on sexual and reproductive health issues in young people, so young being defined as ages 14 to 24 with psychotic disorders. Most focused on sexual dysfunction, which was identified as common amongst this cohort and associated with both psychotic disorders and the antipsychotic medications themselves. And while forms of sexual dysfunction are attributed to antipsychotic medication, sexual dysfunction is experienced by a significant portion of young people with psychosis independently of pharmacotherapy. There's a real lack of interventional studies to manage sexual risk-taking behaviors or STI risk in those with early psychosis, a lack of research on women's sexual health topics, including pregnancy and abortion and early psychosis services, and very little existing work on gender-based violence, coercion, or issues around sexuality and gender. And additionally, very few of the studies included data on sexual preference, sexual gender identity, or provided an opportunity for participants to self-identify. So even with the research we have, there's a lot that's really unknown. And why do these disparities exist that we see? Well, there are disproportionate rates of sexual assault, domestic violence, victimization. Probably the most talked about reason for disparities is side effects of medication. And that's at least one thing that our prescribing and nurse providers might more commonly ask about. But medications can cause much more than just sexual side effects. They can also impact reproductive health. So examples in the literature include infertility, which people with that serious mental illness already statistically experience higher rates of infertility than the general public. Medications can have detrimental impact on fetuses if a participant is taking medication during pregnancy. And I would not, please don't ask me to elaborate on those. We would have to tap into a pharmacist or psychiatrist or somebody in that space because I am a counselor. Other potential causes of disparities are comorbid health and lifestyle factors, things like smoking, substance use, obesity, your standard kind of social drivers of health, as well as health literacy. It can impact sexual and reproductive health. And participants just generally might have a poor perception or awareness of overall risk that they're at. Interestingly, when it comes to engagement in higher risk sexual behaviors, there is a correlation to poorly rated quality of life and more fatalistic views of the future. So when we have people that are rating their quality of life as poor, viewing the future in a fatalistic way, we should be concerned that they might be willing to engage in higher risk sexual behaviors than at other points. So why aren't we talking about sexual and reproductive health more? It's kind of taboo, still taboo for a lot of people. In addition to that, there's a lack of clinician knowledge and training, both on the sexual and reproductive health side and for those who are working in the sexual and reproductive health side on mental health. So not a lot of good collaboration and understanding how to do those kind of cross-skill training, cross-conversation training, I suppose. A lack of solutions is often pointed to, so even when a provider is willing to listen, they don't necessarily feel like they have resources to point people to. A lack of early education about sexual and reproductive health. That lack of education can be heightened amongst immigrant and refugee populations as well. Symptoms of psychosis could overshadow other health needs. So sometimes because of the symptoms themselves, things like paranoia, sometimes because people are fearful of diagnostic overshadowing and fearful of stigma. People turn to social media and informal supports a lot for their information. And parents at this point are not the go-to supports for sexual and reproductive health information among young service users. And of course, things like financial barriers to care, just general access to care. So who is best to ask about any of this really depends on who you ask. There are a number of gender considerations. Female participants tend to have a preference for talking with a female provider about these issues. And gender ratios in things like peer support programs are a potential obstacle to having an open dialogue. Providers are often concerned about offending patients and citing belief that patients will bring up sexual health concerns themselves, or that patients might be offended if they started to discuss sexual health. While patients report an expectation that providers are going to be the one to bring it up and that they would be comfortable discussing sexual health issues with their providers. In a study of 304 primary care patients drawn from 4 community health settings, the investigators found about 90% of the patients think their sexuality and sexual health information is important for their provider to know, and only 10% they think that they might not want to answer such questions on hospital registration forms. Pregnancy and contraception can be sensitive topics, particularly for low-income women and women of color, as their reproductive rights have not always been honored. As recently as the 1970s, women with mental illness were subject to involuntary sterilization, and that whole higher rates of domestic violence and sexual trauma. Clinicians tend to want the system to be better integrated, but the flip side of that is, in this space like this, system service users often would like the system to be a little bit more siloed, separating out their mental health information and their sexual health information. So if you're going to start talking with your participants about their sexual and reproductive health, which from my biased viewpoint, I think we all should be at some point to some degree, we really need to assess our own comfort and biases. So religion, society, culture all influence our views and attitudes around sex and sexuality. We want to create a comfortable environment where it feels safe to talk about those things. So things like establishing rapport, creating an environment that's trauma-informed, having a sex-positive attitude. And a sex-positive attitude is really just an attitude about sex, gender, and sexuality that's free of judgment and supportive of open expression. Sex-positive doesn't mean promoting or discouraging sexual activity. It's just being able to have an environment where it's treated as an open, judgment-free space. Sex positivity is all about re-educating yourself and being open to diverse points of view, accepting yourself for who you are and the different identities that are out there. There are varying options on whether you should discuss this early in treatment with somebody, like say at intake or after building rapport. And I'm sure there's an argument to be made from both sides. Optimal timing really depends on rapport and convening priorities. It can be brought up as early as setting the foundation for this as always an okay topic to talk about. And we could also use universal standard screening. Bringing it up later allows for more comfort in a relationship to be developed first. Sexual reproductive health goals might feel like a sensitive topic. People might not want to discuss them with a mental health provider, so always ask permission first. People might need to understand the purpose of you asking sexual and reproductive health questions. And adverse childhood experiences or adult experiences of sexual trauma or sexual abuse could affect the person's ability to discuss sexual health topics comfortably. So one of the strategies that could be used is taking a sex-positive health history, which is founded in philosophy that consensual expression of sexuality are healthy and strips away the belief that some types of sex are more acceptable than others. So being sex-positive affirms a person's right to enjoy the kind of sex that they're having without feeling judged. And it requires comprehensive education, particularly on sexual practices, pregnancy, family planning, and STIs. So you start by gathering basic information, preferred name, pronouns, gender identity. Make sure to be inclusive, using neutral terms, and ensuring common understanding of the terms that are being used. Transition into asking more sensitive questions. It's okay to ask sensitive questions about sexual health history, explaining that sexual health is an important aspect of overall health. Ask them if they have any concerns about their sexual health, and pose questions in a non-judgmental manner. You might need to rephrase questions or briefly explain why you're asking a certain question if a patient seems offended or unsure if they feel comfortable answering. And if you do get answers that you weren't expecting, try to not react overtly. Even if you feel uncomfortable or embarrassed, it's really important to pay attention to your own body language and posture. When asking about sexual health history, you want to ask about partners, practices, protection, a past history, pregnancy intention, And using basic motivational interviewing skills can help you navigate these conversations with kind of a harm reduction approach. A harm reduction approach in this space would be a way of preventing disease and promoting health that meets people where they're at, instead of making judgments about where we think they should be related to their personal health and lifestyle. A sixth P has been added to the CDC's approach to this, so asking also about pleasure. So including questions like, how satisfied are you with you and your partner's sexual functioning? Has there been any change in you or your partner's sexual desire or frequency? And again, kind of coming at this from a basic motivational interviewing, non-judgmental space is going to be the best approach to this. And getting comfortable is a really big step. One of the studies that I read, the author noted that if you aren't comfortable taking a sexual history from your grandmother, then you're probably not ready to start taking a sexual history from anybody. The 6Ps approach does include a nice little pocket style card, and there is an attached article that I will make sure that I upload with these slides onto iEcho, so you can check that out. So despite all of the challenges, disparities, and what have you, is that I noted, being in an intimate relationship and becoming a parent is reported to be a very strong motivator for recovery for many individuals. Study participants will note that such socially valued roles can provide a buffer against some of the detrimental effects of self-stigma. So as providers, there's things that we can do to support participants' sexual and reproductive health. So things like fostering hope, normalizing worries, providing accessible information and education about sexual health and pregnancy to help people make empowered decisions, support the development of coping skills, maybe engage them in social skills training. For those that are parents, offer parenting classes, help get them connected to parenting classes, and potentially peer-delivered interventions. And as always, when appropriate, we want to engage families, which obviously includes loved ones and chosen families. Family involvement and support is an important way for many participants, and their support can be beneficial in promoting sexual risk reduction interventions as well. These last couple slides, these are a couple really neat resources that I think that people can tap into if they want to dig into some more information or even share information with the clients that you work with and their families. And then some references and a cool webinar that I saw about doulas, if that is relevant to any of the patients that you work with. And I'll stop my share.